our second drug which we will take up is aromatase inhibitor. It comes in variety, but what we use commonly is letrozole. Mode of action is it inhibits peripheral production of estrogen. Thus, with low estrogen, there is an increase of FSH release. So, the mode of action is it inhibits the peripheral production of estrogen. So, that is why it is called the peripherally acting, and with low E2 it increases the FSH levels. It do cause, because it is a aromatase inhibitor, and aromatase is the enzyme which convert androgen into estrogen. So, obviously it is not converting the androgen into the estrogen. So, the level of androgen in the ovarian environment will increase, and this increase in androgen will lead to further increase of FSH. So, it has dual effect that way, that it is decreasing estrogen and increasing the androgens level. So, what are the advantage? Because it has no obvious anti-estrogenic effect, so it is not causing the adverse anti-estrogenic effect of thin endometrial thickness. There is no depletion of E2 receptors like the case with clomiphene citrate, but because it is long binding, so the depletion of receptor is there. It is rapidly eliminated from the body. Somehow there are some studies which say that letrozole has more uterine blood flow and limited number of mature follicle. Again, we are interested in this effect because we want unifollicular growth. Side effect not much, but some of the patient may have hot flushes. She may have fatigue, alopecia or vaginal bleeding, not very commonly encountered. So, it is more or less a very safe drug. Other drugs which we have included in our list is gonadotropin and GnRH analogues. Analog are agonist and antagonist according to the effect. Gonadotropin, first is human menopausal gonadotropin. It can be plain or highly purified, and it is derived from the urine of postmenopausal women, and it has equal amount of FSH and LH. So, if we are taking HMG 75, it has FSH 75 and LH 75. So, second urinary derived is urinary FSH or highly purified urinary product of FSH. We also call them as urofolitropin. So, always remember, one is HMG, second is urofolitropin, and both of them are urinary derived. They are derived from urine of pregnant women, and now here in this case we treat them with antibodies. We are deriving the purified form immunologically. We remove LH part with polyclonal antibody. If we are removing it with removing the LH part, we are recovering FSH. We call it HMG. It's not HMG highly purified, it is Euro FSH. So, there are many companies which have come up with this. Then it has high FSH activity and very low in LH, because LH part has been removed either with the help of monoclonal antibodies or the polyclonal antibodies. What is better in these drugs are, it is more purified than HMG and it is less costly than recombinant. So, if you ask me what is cost effective range, I would say that urofolitropins are the drugs which are highly effective in the good cost range, that it is not very heavy for the patient. HCG is one of the gonadotropin, although it is used to trigger the ovulation because of the high LH activity in it, but sometime in case where we need low amount of LH also, we do use it for ovulation induction also in controlled ovarian hyperstimulation or controlled ovarian stimulation. We know that it is derived from the urine of pregnant women, so it comes under the category of urinary. So, always remember, we have 3 urinary and 1 recombinant category. So, in urinary we have HMG, we have urofolitropin and we have HCG, and in recombinant we have recombinant FSH and recombinant LH. So, we call it and recombinant FSH is folitropin alpha and folitropin beta category. So that has been summarized in a chart according to the purity. Like we told, HMG has purity level less than 5%. LH activity is also 75. They have categorized one category as mean specific FSH activity. I would say it is same. If we are taking 75, it is 75 LH and 75 FSH. Then highly purified HMG, they have also, as we have discussed, the purity level has increased because the impurities have been taken away. Folitropin beta and folitropin alpha, they have only the FSH component, the LH component is 0 in these two drugs. Okay, and they are very, very pure. You can look at the FSH activity level, that is in 10,000 or 13,000 range, so it is very, very effective. Again, we have written the brand name also. HMG is Pergonal, or there is one Humog, Menogon. There are 3-4 companies, standard companies, which have come up with these products. Route of treatment is IM. Urinary protein are as high as 95%. FSH and LH same 75. These are the companies. Price, these are not Indian prices. Then highly purified, they generally have the name pure written behind. It can be Mono Pure, Gona Pure. Generally with highly purified, the route recommended is subcutaneous. You can give them IM also. Impurities, see, level of proteins are less than 5 in them. We have taken the name Menopure from Ferring, but there are many Indian companies also which are providing this. Purified FSH, by Serono they are coming up with the name Metrodin, but again I told you there are many Indian companies which have come up with excellent products. The route will be intramuscular, same, it will be have FSH 75, and look at the level of LH will be less than 0.1 in these. Okay. HCG, highly purified HCG, same way the level of purity has gone down in level of purity has gone up in highly purified. What commonly what we use is highly purified only. We are not using the plain HCG anymore. Then the category of FSH and LH, recombinant ones. Gonal-F, very commonly used, that is folitropin alpha. And there is one Puregon by Organon and Recagon also. These are the commonly used product, and in Indian market they are available by 2 more companies, by Bharat Serum and Intas. They have come up with an excellent product like Folisurge, and the route is mostly subcutaneous, and the level of FSH they are providing depend upon the dose which we have chosen. If we have taken 225, it is obviously giving us a FSH of 225 units. The price, again, it's not an Indian price. The price range is high. One injection of 225 unit will cost somewhere around 6,000 to 7,000 to the patient. Okay. Gonal-F is obviously the non-Indian companies are more costlier than the Indian ones, so we generally switch to the Indian ones when we want the cost to be controlled. There is one recombinant HCG, Ovitril. Okay. It has choriogonadotropin alpha in it. The route of administration is subcutaneous. The dosage is 250 micrograms. This generally we prefer to give in patient either who have not the follicle is not ruptured with a routine HCG, then maybe after 48 hours when it is not rupturing, or maybe in the next cycle we try to give them the recombinant ones, and as a routine in IVF cycle we give the recombinant one. Then recombinant LH is also available in the market by the name of Luvaris. There is only one company at present which is producing it, that is Serono. Okay. The route is subcutaneous, and the standard this is LH is 75 in them. Then there are some more new drugs in the market. There is long acting FSH where It is by the name of corifolitrofin alpha, and the advantage is you do not need to give it daily. It is long acting in the range of 7 days. It acts for 7 days. The only problem why they are not very famous is once you have given for 7 days, you cannot adjust the doses. You have given it and you just are waiting for the effect. While in daily ones, you are seeing them on day 5 or day 6 and you can adjust the dose. Then there are some highly purified urofolitrofin tablets available, although not common in the Indian market, and so far we have not used them. So what are the side effects of gonadotropin? They may cause nausea, it may increase the asthma episode, then patient may have mild erythema or rash at the site of injection. They may have severe anaphylactic reaction. So for the initial dose, we always recommend the patient to take the dose at our place or our center by registered nurse. Thromboembolism not very common, same way ovarian cyst not very common. Pain, redness, irritation, these are the common problem patient may encounter. And yes, last and not the least is ovarian hyperstimulation, which is obviously can be there. So these lecture actually are a kind of revision. When we are taking on whiteboard, we are drawing and telling everything, and PPT takes us through them and revise it again. So this we have discussed in our lecture, that how the gonadotropin agonist act. They just go there to the gonadotrop and bind to the receptor site, and initially the receptor or the gonadotrop take it as a original GnRH, and they start secreting more FSH-NH. By the time they realize that it is not original, they stop producing, and then they are completely down regulated. So there is flare for 6 to 7 days or 7 to 10 days, and then there is complete down regulation. Antagonists, on the other hand, they directly go there and bind, and the action starts immediately. So there is a decrease in the level of FSH and LH when we have given either agonist or antagonist, because the pituitary has been down regulated. There is no secretion of FSH and LH. Now there is arrest of follicular development, decrease in sex steroid level to castrate levels. I mean, we can call it pseudomenopause. If we are giving the gonadotropin agonist for a long time or antagonist for a long time, patient can be in a state of, we call it pseudomenopause, because there are no gonadotropins in the body, there is no ovulation. The pituitary blockade persists during agonist, but it is reversible after the therapy. So now what are the types of GnRH agonist available? These are the standard commercial name: Zoladex, Decapeptyl, Lupron, Luprolide. Sun Pharma is producing Luprolide in India. So you always remember what is there in the Luprolide is Luprolin. What is available in Decapeptyl is Triptorelin, and the doses what they are providing. Luprolide is available as 3.75 depot or 11.25 depot, or a daily dose of 1 milligram per ml. Triptorelin more commonly available as a depot 3.75, that is Decapeptyl depot. Then it is available as 0.1 milligram and 0.05 also. This 0.1 milligram in double dose, like 0.2 milligram, is given as the agonist trigger. So as a trigger, you can give a Decapeptyl of 0.1 milligram or 0.2 milligram. You can give a trigger of Luprolide, that is 1 milligram or 2 milligram. Buserelin is available as nasal as well as subcutaneous. Dose is 0.5 milligram. It is also available in Indian market. Neferalin 0.2 milligram twice daily. It is available only as nasal dose. So in Indian patient, we do not use nasal very commonly, because we do not know how they will use it, whether they will use it properly or not. So better is to give them the injectable one. So what are the effect of agonist on the body? Flare effect. It starts within 12 hours, and there is 5-fold increase of FSH, 10-fold rise in LH, and there is 4-fold elevation in the estrogen levels. With continuous administration, the opposite effect starts. Now we call it the internalization of the agonist or the receptor complex and decrease in the number of receptors. It also called as down regulation. And paradoxical suppression of the pituitary gonadotropin synthesis and liberation is also known as desensitization of the pituitary. Our next drug is GnRH antagonist. So they are competitive inhibitors for native receptors. They are going there and just binding to the receptor and suppressing it. Immediate effect but reversible. Third generation drugs are commonly using a cetrorelix and ganirelix. The newer one are ramorelix and ORG 30852, although they are not commonly available in the market. So in market we have cetrorelix and ganirelix to be used. They are used subcutaneously, and the standard dose of cetrorelix is 0.25 milligram or 250 micrograms. It is available in a doses of 3 milligram also, where it can be given single dose. So single dose is 3 milligram, daily dose is 0.25 milligram. Ganirelix again 0.25 milligram and subcutaneous. Both are same, whichever you want to use you can use. And Indian companies are producing more of cetrorelix than ganirelix, so we are more using more of cetrorelix. Side effect, there can be again minor site reaction. Patient can have nausea, headache and fatigue. So difference between GnRH antagonist and agonist. Antagonists have receptor blockade without receptor activation. In agonist there is activation and then desensitization, so we call it receptor downregulation and pituitary desensitization. It is a competitive type of inhibition, so immediate and dose dependent suppression. Rapidly reversible, slowly reversible. So we have a list of adjuvants which we give to the patient. Metformin, number 1, most commonly given to the PCO patient. Again in the lecture of PCO we will discuss which patient need metformin and which patient we do not need to start them on metformin. There are growth hormone which can be given alongside control ovarian stimulation for better ovarian response. Dexamethasone again in PCO patient who needs and who do not need in PCO lecture. Low dose aspirin to increase the uterine blood flow, and dopamine agonist like cabergoline, bromocriptine, mainly bromocriptine, and this can be given, and then androgens can be used in poor responder patient. So whatever Cochrane review and data is available, except for metformin which has standards defined role, all of them have hit and trial method. They may work, they may not work, so they do not have standard doses, protocols and all that as per meta-analysis. Metformin we will discuss in detail in PCO patient. Thank you. I think I have taken all the drugs. So we will be going ahead with the protocol lecture.